And welcome to Deuk Spine Institute. It is now Tuesday, March 12th, 2024. Our patient has 3 bad discs we're going to be fixing with our laser surgery. L3-4, L4-5, L5-S1. She has a lot of other issues like scoliosis, osteoporosis, degenerative disc disease, but the main focus is getting rid of her back pain and leg symptoms. All right, right approach L3-4, left L4-5-5-1. We're starting on the right side. I'm going to get started at 3-4. I'm going to access the L3-4 disc transforaminal with a needle. Shot. All right, 5, 4, 3. So a little bit too high. Jordan, you're going to have to work a little bit to get that x-ray just perfect. She has a lot of scoliosis, so it's not going to be an easy one for us to do. When you have scoliosis, you have to adjust your x-ray, and we call it wagging and orbiting. Those are the 2 planes of movement, and to help see it better. All right, show us 5. Yep, 4, 3. And show us 3, 4, right there. Now you see how it's not lined up? We need to get it lined up. So you need to wag, just choose a direction. You're off by about 2 degrees. That is better, actually, really good. Hey, I like it. Look at the vacuum space phenomena happening at 2, 3. We're not treating 2, 3, we're treating 3, 4. Shot? 4, 5, and 5, 1. Okay, you're off on orbit. Look right at the tip of the needle. Do you guys see that black line that's kind of going sideways?
Yes, we do.
Right there, Jordan is highlighting it. That is the front of the facet on one side, and show us the front on the other. Good job, Jordan. So, because the facets are not lined up, because it's an orbital failure, we need to adjust the orbit. Okay, there we go. That's almost perfect, but not quite. I think we're off on wag by ½ degree and orbit by maybe a degree. Shot. All right, shot. There's too much movement. That's damn good. That's as good enough for government work, as we say in the biz. All right, here we go. I'm going to go for it because I'm happy with that. Shot. Any questions? Go ahead and ask. Otherwise, shot. AP. Henry, go ahead and show our audience, how is it that these disc injuries called herniated disc, bulging disc, ruptured disc, protruding disc, extruding disc, slip disc, bulging disc, whatever, how is it these disc injuries cause so much pain? Welcome back. Now you understand how it is that a disc injury, which is really a annular tear and herniation, how those disc injuries actually cause so much pain. Yeah, we're way past midline on 3-4. We can come back a little bit. All right, shot. Good. Again, what makes it more challenging here is the fact that she has some pretty bad scoliosis. We're now into the 3-4 and 4-5, and we're doing 5-1, correct? Yes. Everybody agrees? Now typically I do 5-1 first, but I didn't do that today. You're doing great.
Lay still. You're doing really well.
We're going to have you asleep soon. Any questions?
At this moment, no current questions.
Wonderful. Shot? 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 Five one is not gonna be easy. Shot? You're doing great, Shot. All right, well, Henry, if there's no question, Shot, let's do an AP and let's show the audience exactly how we fix these problems. We've shown you the problem, a tear within the wall of the disc in the back that gets the nuclear material from the center gets stuck in it and it starts to cause inflammation and pain. All right, lateral, lateral. So that's what we're here to fix, is that tear. We call it an annular debridement. And Deuk Spine Institute's the only center in the world that does annular debridement routinely, and we're the ones who pioneered the treatment. You're doing great. Welcome back. So we're almost done accessing the discs. L4-5, L5-S1, L3-4. We're going to put you to sleep. Just hang in there for another minute, all right? You're doing great. Just lay still. I can't have you moving around. All right. Shot. All right. So, very degenerated 5-1. You're doing fine. Everything's okay. You're doing great. We're going to put you to sleep in just a minute. So I'm trying to get into the 5-1 disc, and I'm literally sitting on the back of it, and it's collapsed and full of bone spurs and scar tissue, so clearly it's not an easy thing for me to do. But we're really close. You're fine. You're doing great. Lay still. I don't want you to lift your head up. We're almost done. We're going to put you to sleep, all right? I just need your help for a second. Sean? So I may not be able to get into 5-1 for a discogram. But that said, I'm still close enough to definitely be able to do the procedure. So that's the most important thing. All right. Are you comfy? Just lay still. We're going to need your help. Now, how long has she had back pain for? Dock her pay. Lower back pain. How long have you had back pain for?
How many years?
You having any pain right now? Okay. She seems to be pretty comfortable. Shot. How bad is that on a scale of 1 to 10? How high does it go? What's the highest? Scale of 1 to 10.
Give us a number. Did you say 10?
10. All right. Is that where you typically get your pain? Yeah? All right. Is that better now? So you can see the tear in the disc, Sean? All right. You more comfortable? Yeah? How bad is that on a scale of 1 to 10?
Give us a number.
How bad is that?
What'd you say, 10?
10? 10. All right, we're not going to be able to test the last one because we're not all the way in. We're right at the back of the disc. So for L5-S1, we're just going to have to put it in while she's asleep. All right, so she's having back and leg symptoms both. We're going to be treating both today.
For 5 years.
For 5 years is what I'm hearing. All right. It's actually longer than 5 years, but the problem is a lot of patients, when you ask them, how long have you had it for? They kind of tell you when it's really been the worst. Shot? And the truth is, they've had it maybe for 20 years, but it's been on and off, comes and goes. And what I'm more interested in is how long ago did it start? Because it's really the start of the back pain many years ago when people's lives get changed. That's when they start changing everything about their life. Shot? They change their activity levels, they stop playing sports, they stop doing things they enjoy doing. And so the impact on the life starts when back pain starts being chronic, not when it gets real bad for the last 5 years. All right, Henry, any questions?
So far at this moment, no current
Shot?
questions.
All right, we're going to start by placing our dilator into the disc at L3-4 on the right side. That's our first disc we're going to fix today on her. Shot? Looking good. She's asleep. She's nice and comfortable. This is the most painful part of the surgery, is, you know, putting the dilator in through the tear. The tear is already there. The tear is there, and that's how the herniation came about, is through the tear. So what I'm doing is I'm putting my tube through the disc wall right where the tear is. So we're actually not damaging the disc. A lot of people wonder, is this surgery damaging the disc? It's not, because we're going through the damaged part of the disc already. So we're not doing any additional damage. We're going to go and repair it. We call it the Deuk laser disc repair. Some people get confused about that terminology. We're not actually putting metal or sealing it. What we're doing is we're cleaning the tear so that it'll repair itself. Same thing happens, for example, with fusion. We're not actually doing a fusion. The body does the fusion after we're done with the surgery. Most people don't know that. When we do a spinal fusion, we're not fusing, we're doing what's called an arthrodesis, which is where we're putting bone graft there for the spine to fuse. But fusion is something the patient does. And it takes patients on average 6 months to a year really to form a fusion. Early fusion at 6 months, and mature fusion by about a year or two after surgery. So when we say we're doing a fusion, as surgeons, we're not actually doing a fusion, we're setting the patient up to fuse. Okay? Same thing here. We're not repairing the defect in the disc, we're debriding it so that the body will repair it. The best repair for a disc is one where your body seals the disc. We as surgeons can't do better than your body. Your body healing itself is the best treatment for an annular tear. However, Your body cannot heal an annular tear when there's a herniation in it. This, huh? All right, any questions, Henry?
At this moment, no current questions.
All right, let's show the audience then how this Deuk laser disc repair works, if we haven't done that yet.
We have, but we could show it again.
Let's show it again. Okay, great. So you can see from our video that we're using a tube to get down to the tear and herniation. We're using a laser to remove the herniation and clean the edges of the tear where the inflammation is. So it's a two-step procedure: remove the herniation and clean the tear. The cleaning of the tear, which includes removing the herniation, we call it debridement, annular debridement, because we're debriding the annulus fibrosis, which is the outer wall of the disc. Normally, the outer wall of the disc is painless. There's no pain from it. It only becomes painful when there's a herniation stuck in it, causing the body to attack the herniation and create inflammation. That's how your body attacks it. It's a primitive system of defense, the inflammatory system. The immunological system is far more advanced and doesn't cause these kind of problems that the inflammatory system does. A lot of our diseases today that humans have are a result of the inflammatory system. As a matter of fact, almost all disease of the human body comes from inflammation. Whether it's coronary artery disease, atherosclerotic disease, even cancer is believed to come from chronic inflammation. Inflammation causing the body to respond by releasing very powerful chemicals called cytokines. These cytokines have powerful physiological actions on the body, on cells, on tissues, and things like interleukin, tissue necrosis factor. I mean, there's literally hundreds upon hundreds of cytokines produced by your body's cells, and many of them are produced in response to inflammation. And of course, what causes inflammation? Typically, when your body's inflammatory system recognizes something as being foreign, not part of yourself. Okay? Bacteria, fungus, herniated disc, piece of wood, splinter in your finger, many things your body's inflammatory system is going to recognize as not part of yourself. God damn it. And therefore it's going to attack. And the attack is brutal and vicious. After a while, you get scar tissue formation from the constant attacking and destruction. Any questions?
At this moment, no current questions.
Are we even streaming?
Yes, of course we are, yes. We have a good amount of viewers as well. It's just no one's.
Interesting. So
Yeah.
maybe our new video animations are answering all the questions.
I believe so.
You know you've created a great educational tool when people don't have any questions. Right?
Yeah, I would hope so.
All right, so what am I taking out here? These are all pieces of herniation. And some people are surprised to learn that herniation is not one thing, it's many. So these herniated discs are never one piece of herniation. There's always multiple fragments, we call them. Look at all these things. Little snowballs. Some are small, some are big, but in the end there's, I'd say, an average of between 30 to 50 pieces in a symptomatic disc. But what does that mean? It means several things. Number one, many herniations are without symptoms. In other words, you can have a herniated disc and not have any symptoms at all. Guess what? We don't treat those typically. Now that may change in the future where we do want to treat them to prevent them from becoming symptomatic in the future. But right now we don't typically treat them. I think it's possible we'll be treating them in the future. Asymptomatic disc herniation. Because eventually they all become symptomatic. That's the problem. All right, you can see more of the tear. Has the blue stuff in it, which is the herniation. How is she doing, Dr. Berndes? Good. Now, where is she from? Huh? Well, where is this patient from? So she's local. All right. Yeah, we have a run of localites. Yeah. So we have one more case after this, which is a DPR, right? And what are we doing? I know that, but what are we doing? Luis, do you know?
No, it's a bilateral 4-5 L5-1.
Okay. Very good. So, our last procedure, it's the last one, right? It's a Deuk plasma rhizotomy for facet joint pain in the lower back. So if people have back pain, the most common reason, about 85% of back pain comes from a herniated disc, just like the ones we're doing here. Okay? And then about 10% of back pain comes from facet joint injuries, arthritis of the facet joints. This patient has disc pain. The next patient has facet pain. Many patients have both, disc and facet. Matter of fact, the last patient, the first one we did in here today, had both. And he had piriformis pain as well. So his back pain came from the left piriformis muscle, 4 facet joints, and 3 discs. No, 2 discs. One of them was a bilateral because he had bilateral leg symptoms.
We have a comment and a question.
Sure.
The comment comes from Angie on Facebook.
Angie, welcome to our live stream.
They said I seen my regular doctor on the 4th, and I told her about you and gave her your info. She is going to send my MRI disc to you. I am going to speak to someone here locally to get mine pre-approved.
That's wonderful. I'm so happy to hear that. I would just caution you, many times patients rely on doctors or centers to send their MRI, and they never get sent. And then the patient starts calling around saying, what happened? I thought you got my MRI. And we say, no, we never got it. And then they spend a lot of time and effort trying to figure out where things went wrong. And in the end, I can tell you where they go wrong. The doctors don't send the MRI. That's the problem. Or the MRI center doesn't send it. So my advice to all my patients is get a copy of your MRI yourself. And then you make sure we get it. You send it. Now, if your doctor is really that responsible, great. But I rarely see doctors that do that. It's very rare. Very common to see people calling saying, did you get my MRI? No, not yet. A week later, did you get my MRI? No, not yet. They said they sent it. Yeah, well, we didn't get it. So, unfortunately, that happens all too often. And the reason is because they don't send it. Now, I'm sure the doctor is not going to personally put the MRI in a FedEx envelope. So they're going to rely on their staff to do it. And staff are busy, you know, and sometimes things like that get swept under the rug. I'm just cautioning you. I'm not saying that's what's going to happen, but it wouldn't surprise me if it did. But I look forward to reviewing your MRI, giving you my piece of advice.
Next question. This comes from Nicholas on Facebook.
Hi, Nick.
Asking, I'm not sure if my question was answered regarding the difference between Deuk laser disc repair and disc seal injection. I will send my MRIs as soon as I get it.
Yeah, there's too many differences for me to tell you about all of them. Disc seal, all they do is stick a needle in the disc and inject some material that doesn't work. That's probably the biggest difference. Disc seal doesn't work. Deuk laser disc repair does work. This is a surgery. Disc seal is not a surgery. Disc seal is an injection. Okay? I don't know any injection that works. We have lots of patients who come here after disc seal because they're still having problems. And when I say they're having problems at the disc that was treated with disc seal. In other words, the disc seal procedure did not work. So once again, disc seal, they're just injecting medicine in your disc. With Deuk laser disc repair, we're going in and operating on the disc, using a laser to clean it up. It's not done in disc seal. And if it is, then they're doing the Deuk laser disc repair. Because we're the first to do this in the world, and we're the first to publish it. So nothing's going to keep other people from doing this. If they really want to, they can. But that doesn't make it their own procedure. It's still the Deuk laser disc repair, not a disc seal. My advice is watch a few of these surgeries and you'll get a pretty good idea of the difference. But again, the most important is that the disc seal doesn't work, in my opinion. And I don't see how it could work. I hope I've answered your question. Well, at least I hope you heard the answer. All right, just about done with the first disc. Then are we switching sides, Luis? I'll head over to your side. Just really very badly damaged disc. A lot of scar tissue. Any more questions?
No good questions, but we do have a comment from Billy on Facebook
Sure.
saying, whenever I watch this, I find it amazing.
Thank you. Yeah, it's pretty cool to be able to see inside the disc where the problem is. We're looking right at the herniation and kind of taking it out piece at a time. Just about done. You see how the laser by itself can't do everything and the grabbers by themselves can't do everything. It's really teamwork between the laser and the grabbers working together to release the herniation and then remove it, to grab it out. Not so hard, Luis. It's just it's really more strategic than it is brute force. Okay? Yeah, it's a pinch in the right spot. And that does it. All right, this is looking pretty good. I think there's just that last piece there, and we're done. All right. Here you go.
Too long, please. Thank you.
All right, all done with one. Keep the questions coming. Happy to answer them.
This next question comes from Alan on YouTube. Alan on YouTube asks, you mentioned bone spurs for this patient. Is that repaired during this procedure?
Yeah, bone spurs don't need to be repaired. The number of bone spurs that need to be repaired is 1 in 10 million. So if you're that one person in 10 million with bone spurs that need to be repaired, we will repair it. The good news is almost every human being alive over the age of 40 has bone spurs, but very few of them have any symptoms. Bone spurs, most people think bone spurs need to be fixed because they're lied to by their doctors and told, look, you have bone spurs, you need surgery. So it's a way to get you to do their surgery. I never tell people they have bone spurs, they need surgery. That's because bone spurs are never needed to be operated on. Okay.
We don't do cosmetic spine surgery.
Yeah, we don't do cosmetic spine surgery. We're not here to make your spine look good. Get rid of bone spurs. We're here to make your spine feel good. Most people want their spine feeling good. If I gave you the choice, your spine can feel good or it can look good, but you can't have both. That's how most spine surgery is. It's either going to have, I need a picture. Thanks. You can have spine surgery where they put screws and rods and cages or artificial discs and it looks really sexy, but then you have pain afterwards and life sucks and you're no better off functionally. Or you can have a surgery that fixes your problem and you have no pain and you go on with a normal life, okay, but your spine looks the same. Okay, that's what we do. You're not going to have a dramatically different looking spine when we're done, but you're going to have a dramatically different feeling spine. And we're the only ones that offer that. Okay, shot? Other doctors will promise you fusions and cages and artificial discs, and they'll have them in their office so you can look at them, and they look real sexy. And they're like, look at this thing. It's got metal and plastic, and it wiggles and jiggles, and it does this and it does that, and 30 degrees and 48 degrees, blah, blah. And in the end, you have it in, and then you're in more pain, or it pops out. You're having complications, blood clot, pneumonia, DVT, heart attack, stroke, or you're just dying. And you're like, why the hell did I have that surgery? You don't believe me? Just go on the internet. Read about all the people that have artificial discs, laminectomies, discectomies, whatever, fusions, and they're in horrible pain. They're miserable, okay? And their spines look really good with all that metal in there, but they don't feel good. They're horrible. If you talk to most spine surgeons and they tell you about fusion, are you going to, just ask them, are you going to cure my back pain? Their answer is going to be, you have a 50-50 chance of getting better. Well, first of all, I don't want to be better. I want to be cured. Second of all, I don't want a 50-50 chance of being better. I want a 100% chance of being better. So why would you sign up for a surgery that offers you a 50-50 chance of being better? You must be stupid when somebody else is doing surgery that's a 100% chance of being better, and almost every time you're getting cured. So we don't operate on bone spurs. We operate to get rid of pain and restore function. That's really what you want. You may not realize that's what you want, but trust me, after being a neurosurgeon for 26 years doing spine surgery and doing every single spine surgery out there, I know what you want. You want to have no pain and back to a normal life. Okay? And this is the best surgery in the world for that. That's why we do it. Deuk Spine, we could do any surgery we want here. We could take out tumors out of your spine. We've done it. We could fix fractures. We could do fusions. We could do artificial discs. We can do laminectomies and discectomies and laminoplasties and foraminotomies and barricades and disc seals, and anything we want to do, we can do. Because we have all the equipment to do it. And we have all the ability, technology, staff, training. We do it all. But we don't do it because it's unnecessary and bad for you. All those expensive, invasive procedures don't help the patient. They help the company that makes the device. They help the surgeon to make more money. They help the hospital to make more money. But they don't help the patient. So they're all being done at your expense. Even the insurance companies benefit because there's so much negative publicity from these procedures that they cover, the fusions, the laminectomies, patients being miserable, suffering, in pain, all over the internet, all over social media, complaining, that everybody picks up on it. And the insurance companies benefit because when the surgeon tells you you need a fusion, nobody wants it. So you guys come out and you search for alternatives, and you end up finding my site, which is exactly what you should be doing. And the insurance companies are very happy that you guys don't want fusion because they don't want to pay for fusion. It's expensive for them. But if they tell you you can't have a fusion, you're going to get angry with them. So they want you to tell yourself you shouldn't have a fusion. That way you're not angry with the insurance company, you're angry with life because there's no better option. But there is a better option. That's the whole point. Just you're not being told about it. Now you are. And we're not here to fix your bone spurs. We're here to get you out of pain. We had one guy who kept coming here, and you got to put the pedal of my left foot. You understand? Not over here. I can't face this. I'm facing this. We had one guy who kept coming in asking the same question about bone spurs. I think I told him 5 times, you don't need bone spurs removed, but he keeps asking the same question.
Someone must have put that question in his head.
No, it's one thing if you are told something and you want to know the truth, you go out and find it. Find the truth. You ask an expert like me, what's the truth, right? But then if you have to ask the expert 5 times the same question, are you expecting a different answer? I mean, there's a personality disorder or there's some kind of a memory difficulty remembering that you already asked the question, you already got an answer. Either way, it's a waste of my time and everybody else's. So, all right, Henry, you have any more questions?
Yes, this next one comes from Nicholas once more on Facebook.
Wait, before you ask it,
No worries.
I'm going to guess it's a bone spur question.
No, I don't think it is.
All right.
You be the judge. But they asked, so the annular outer layer will close up by itself after herniation removed? I always thought it can close on itself.
It cannot close. You see this right here, Nicholas? This big fleshy thing, that is the herniation. The annulus cannot grow through this. It's blocking it. That's why the annulus can't heal. When I remove it with my laser surgery and my grabber, now the annulus can close up. But it is impossible for a herniation to heal itself. It doesn't happen, ever. Now, it can stop hurting for a while, but then it's going to come back and hurt again once you irritate and aggravate it. It's like having a thorn in your skin. The thorn is not going to go away on its own. It will not dissolve. It will not disappear. It's a physical structure, a piece of wood. Your body has no ability to remove it. Okay? You need somebody to take a tweezer and pull it out. That's what I'm doing. This is the giant tweezer right here. It's called a laser. We're tweezing it out. Okay, now, when you have a thorn in your finger, it hurts like hell, right? But then it starts to die down. It doesn't feel so bad. And you start having a normal life. And then you bump your finger against the wall, right where the thorn is. And guess what? It hurts like hell. And then it starts hurting for a while. And guess what? Pretty soon you start to train yourself that every time you bump that finger against the wall, you're going to make pain. So your body starts to learn not to use that hand, not to use that finger. Now you're walking around not using your hand anymore because every time you use your hand, you bump your finger, the thorn digs in, and it makes pain. That's what people with back pain do. They're not getting better. They're learning to adapt to their disability. This surgery is the only surgery in the world that gets rid of the thorn, and it does it outpatient, safe, and very effective. Nothing else in the world does this but this surgery here at Deuk Spine. So if you want it, your thorn removed, you come here. We take thorns out of your spine. You like that, Berndes?
I saw one on the billboard, I didn't even notice.
You saw what? Huh? You mean outside? Is it outside? Yeah, I was gonna say I don't have any billboard advertisements, but oh yeah. Of all the discs I've fixed, these are the ones I hate the most. Huh? No, they're not puffy. They're scarred. There's all this scar tissue. And what it does is it makes it so I have to pick it out one freaking piece at a time instead of coming out quickly and efficiently. It's just like, this is what they call crab meat. Okay? I don't think it's crab meat, but it sure looks like it, doesn't it? Fuck. It just takes forever. You got more questions there, Henry? And worst of all, they block the view, so you really can't see.
Yes, we do have another question coming from Nicholas once more on Facebook,
Sure.
asking, how can you know when the herniation is completely removed without also removing the good
Come
part
on.
of the disc?
I put it the same place every time, Luis. Yeah, first of all, we're never going to get all the herniation, ever. So that's rule number one. So, I don't need to know when all the herniation's removed because we're never going to remove all the herniation. We leave about 50%. There's no surgery in the world that removes all the herniation. I'm not sure if somebody told you that they do, but no surgeon removes all the herniation. It's not possible. Second of all, I know where the normal disc is. It's called knowing your anatomy. As a spine surgeon, I know where everything is. As a very well-trained spine surgeon. Not many of people are like me, which is why many surgeons have complications, because they don't know where everything is around the spine or they're not paying attention. But when you know where the blood vessels are, where the veins are, where the structures are, the organs are, and you know where they are around your fields of where you're operating, you pay attention to them. You make sure you don't damage them. So I know where the normal disc is. And it's not anywhere near where I am. It's far away. Okay? And that's where we want it. A lot of things are protected by this tube. You guys see the metal tube that I'm working in? Just outside that tube, there are nerves. You don't want to damage those nerves. There are blood vessels. You don't want to damage those blood vessels. So they're right outside that tube. And that's why I put the tube here. It creates a safe working environment. It's a safe channel for me to do my surgery and not harm or damage any kind of vital structure. Okay, so this tube is here for a reason. It's not just so I could see what I'm doing, but it's also to protect things. It has two functions, three functions. It's also to suck out all the pieces of herniation like this right here. You guys see that? That's a big piece of herniation right there.
Yes, we do.
And so the tube is a conduit for me to be able to remove things like that piece of herniation right there. There it is. Move your hand. You guys see that?
Yes, we do.
All right. So the tube does remove irrigation, remove blood, block me from damaging things that are near the spine, around where I'm working, and remove pieces of herniation, and provide a way for me to see what I'm doing. You guys get it? So the tube has many functions. It's called an endoscopic retractor. Tubular retractor, endoscopic retractor. Just about done. Great question though.
We have another question.
We stay away from the normal disc, that's for sure. The normal part. That's why this procedure is not a discectomy. This is not a discectomy. A discectomy, you're taking the disc out. We're not taking the disc out. We're taking the hernia out. Okay, there's a difference. The hernia we want to get rid of. The disc we don't. We want to leave your disc here because you need it. You need it to function. It's a joint. Your disc is a joint. Joints are needed by your body to move. Why would we want to damage the joint any more than it already is? We're trying to repair it. So we just take out the part that's, causing the symptoms, which is the herniation. Clean up the tear because there's scar tissue and junk in there. And by doing that, we already did 2 on the other side. Oh, okay, there's 1 more left, 5-1. I was looking for the needle. It's hiding behind my 2. How funny. I'm like, I know there's 1 more. Yes, Henry, we'll take a question.
This question, and we have another one as well. This one, first one comes from Teresa on Facebook.
Sure.
Teresa asking, can this surgery correct cervical myelopathy?
Yes, it can. The surgery can treat the cause of cervical myelopathy. Cervical myelopathy is spinal cord dysfunction in the neck.
No, he's in place. Do you want to do it? It's good.
Oh, look at that screw for that hip replacement. You see that?
Yeah.
So cervical myelopathy means spinal cord dysfunction. Are you in position there, Jordan? Oh, let's see here. And what causes spinal cord dysfunction is probably pressure on the spinal cord, right? And what's causing the pressure on the spinal cord is herniated disc, usually. Sometimes a bone spur, but about 98% of the time it's a herniated disc. Shot? So, keep going. Shot? Perfect. I got it. if I go in there with the laser and I remove the herniated disc, then yes, we fixed the problem. Shot? Man. Shot? So I'm trying to remove the needle, but leave the guide wire, and I got it. The needle is like grabbing the guide wire. There we go. Shot? You see that? Just compressing it. You got to be careful if you do these surgeries. When you place your guide wire and then you take your needle out, it's really easy to pull your guide wire out with the needle. You don't want to do that. That's going to create problems, because then when you go back in with the dilator and your guide wire has moved to a different location than where your needle was, then then basically you can hurt the patient, because now your guide wire has moved from where your needle originally was. So you have to always preserve the position of the guide wire inside the needle where the needle was. You can't take it out and then re-put it back in, because it's the needle positioning. When you went to place that needle originally, that's where the patient was awake, and you're avoiding damaging anything like the nerves and other structures, because the patient's awake to tell you if you're too close. And then by the time you by the time you get there with the dilator, if you've moved, then you're in trouble, because you won't know that you moved, and you can end up going in a different place than you originally were intending to go with the needle. Shot? So I don't know if that makes sense to you, but it's important that you don't let the guide wire move while you're taking the needle out. Let's just put it that way. I don't really talk much about that during the surgery, but that's a very important thing that I'm paying attention to all the time. Shot? All right, just give me a second. Wow. Man, your anesthesia made it so I can get in really easily. Huge tear. Huge tear. I mean, that dilator just went in so easy. So, I think my needle was just getting caught up on a bone spur in the back. And then, now that she's relaxed, yeah, I can get the dilator in easily. All right, we're in the last disc, L5-S1. We're going to go fix this one. Remember, she had 10 out of 10 pain at 3, 4, 4, 5. I didn't get to test 5-1, but I think she has pain there too, because that's kind of where her pain was, in that area. Any questions?
Yes, we have 2 questions so far. This first one comes from Adele on YouTube,
Hello, Adele.
asking how far back into the annulus must the herniation be to be removed for the annulus to close? 1/8 of an inch or more?
It's a good question. So, so first of all, let's talk about the annulus. A lot of people don't understand the annulus. It's a wall. Okay, it's very strong, very tough, very fibrous. And it's made up of collagen and elastin. 5 minutes. Now, that's your body's best tissue for what is called connective tissue, collagen and elastin. Okay, it's how your body holds all the organs, all the tissues together. You understand? It's what holds us together. So your body God chose to use collagen and elastin for the wall of the disc. And it's the best choice, to be honest with you. It's just that, unfortunately, because human beings are now doing things, activity-wise, that we were never doing. Just be careful if don't take offense to what I'm about to say, but that we weren't doing, millions of years ago. But now we're in cars, driving around at high speeds, we're skiing down slopes at mountains, and we're engaged in basically high-speed, high-force activities. And so if your body suddenly stops or moves, one part of your body moves one way, the other part moves the other, you're now going to create a force on your disc that's massive, a massive force that can crack your annulus, which, by the way, would never happen a million years ago, because we didn't have cars and boats and we didn't have motorcycles and things like that, right, to propel us so far, so fast. And if you fall off a cliff, you're dead anyway. So the disc was really well designed for us for a long time, okay? But now with this new era of high-speed transportation and movement and, you know, activities like football, whatever, that you can get, you know, tremendous force put on your disc, they fail, they tear. So there's 5 types of tears. There's tear 1, 2, 3, 4, 5. First grade tear, grade 1 tear, is just the inner wall, like the inner third of the annulus. A grade 2 is the inner third and the middle third, and a grade 3 is all the way through to the outside. You must have a grade 3 tear in order to have pain and a herniation. And then grade 4 means there's a tear and it's through the wall from inside to outside, as well as a herniation stuck in the tear and sticking out the back end around your nerves. Okay, that's a grade 4. Grade 5 is just a huge extruded disc fragment through the tear. So 5 grades of tear. You need a grade 3 or higher in order to have painful disc.
We have another question.
Yep.
This comes from Nicholas once more on Facebook.
I need about a minute left and I'll be done with this. Yeah, go ahead.
Asking, post-surgery, would we have to wear a collar to be delicate with the neck? I feel
Yes.
I may want to avoid movement until it's healed.
Yeah, so Nicholas, if you're having the laser surgery by me on your neck, then you need to wear a collar for 6 weeks after surgery. And the reason I put patients in a collar is to help prevent what's called hyperflexion, where you flex forward suddenly, snap your head forward like coughing or sneezing. I've actually have, for those of you who don't know, our reherniation rate is 1%. That means 1 out of 100 of these patients will reherniate. Okay? We know that because we've seen it. And what happens is the ones with a neck disc reherniation, where they re-injure, are always related to a hyperflexion injury, where they suddenly snap their head forward, like coughing, sneezing. I had one patient who had COVID and she coughed violently at home. She wasn't wearing her collar. She reherniated. I had another patient who had COVID who sneezed and reherniated. All right? I've seen it. It's real. It happens. And that's why I tell them to wear a collar for 6 weeks. Okay? If you don't wear it, doesn't mean you're going to reherniate, for sure, but it increases the chance that you will. All right, I got about 30 seconds left, and we're done. Our next surgery is going to be a plasma rhizotomy for facet pain. Where are we going for the last surgery? Here. All right. So you guys can watch it. Scope use was an 8. Any other questions?
No current questions.
All right, thanks for watching. And everything went great for her. Fixed 3 discs. She was having back pain as well as symptoms into her legs on both sides, her thigh and her calf, and from the pinched nerves. So I think she's going to do really well with this surgery. And it's Band-Aid incision, you know? No hospital, outpatient, very little blood loss, you know? Basically the amount of bleeding you get from a nosebleed, that's all. And she's going to go home in an hour. And she's going to rest at home and recover at home. And then she'll be back in the morning for a quick checkup. And hopefully she'll be doing great, which I expect she will. But yeah, her surgery went really well. All right. What typically bleeds is the muscle, because the muscle has so much blood supply to it that as we pass through it, it creates a little channel and until the fibers close back together. And so, now I don't like the blood getting in the muscle because it causes an irritation of the muscle as it breaks down. And then people get muscle spasms. And I had one guy, he worked on a cruise ship, and he had this kind of bleeding that went in the muscle. He had 3 months of pain and then it went away. 3 months. And that was when I realized, you know, you want to try to prevent that. Normally we don't care about that kind of stuff, but when it causes pain for the patient, you start to care. I can hold this for a minute while you clean up and help facilitate. Do you want me to put a bandage on? All right, if there's no more questions, we can end this.
No problem.